check if you have not muted your, oh, thank you. If you have not muted your line, if you will please do so. I don't want to hear any PHI or private conversations of whoever runs into your office or calls over the intercom, nor does everybody else that's on here. So, and I know that occasionally happens. We got things that are happening. That's why we're recording this. I will tell you, we're recording it for those who are not able to make it today. You received an email from me within the last hour that it has 2 documents in it. One of them is a slide presentation we're going to go over today. One is a associated document that has a lot much more detail that's included in it. I'm going to say this probably 3 times. The first time is going to be now. This information is for your eyes and ears only. You'll understand by the end of the presentation why that is, not to be shared externally, and really ask you to keep this within yourself, or if you've got a CFO or someone on your senior team, you need to work through it, that's fine. But this is not for really sharing with boards or anyone external, especially any of your legislators from your local areas at this time. We'll key you off when that is the right time, and this is not designed in a format for that type of presentation. This is really designed for each of you that's got a lot more background and knowledge in healthcare. And so with that, I'm going to get started here. As we discussed today, a new state-directed payment proposal. You may hear me during this presentation refer to it as a supplemental payment or an SDP, a state-directed payment. Those are all interchangeable. And I apologize, I'm going to try and stick to state-directed payment, but no guarantees. I can get this slide to switch for me. Come on. There it goes. So where do we start at? Where are we at today? What's the problem we're trying to solve? We've got our hospitals in a current situation of trying to maintain services and access to care for your communities. Sometimes that's, and hopefully within your communities, but sometimes that means it's for your communities with associated transfers to other hospitals where services are available. But we're struggling financially. For those who are on the member call a few weeks ago, 2/3 of our hospitals lost money in the last fiscal year that they have reported, so for 2022 time period. Medicaid is very high in our state. We know that 48% of our states are Medicaid. Again, whoever's on, please make your call. And Medicaid doesn't reimburse, reimbursement does not cover the cost, neither the direct base payment nor the summary of payments that would include any supplemental payments that we receive. It still reimburses below the cost of our care. And our current supplemental payments for those who are safety net care pool hospitals, that's not covering the gap. And in fact, they're not even functioning in the intended purpose, intended purposes for which they were created. We've spent a lot of time over the last 20 months trying to meet HSD's request to adapt TAP into a value-based purchasing component, and TAP is totally irrelevant to what its original purposes were designed for yet. So as we look at that, that's really, these are things that are driving us to be here today to have this discussion. So if that's the problem, what's the opportunity? Fortunately, this last spring, CMS has come out with new clarification and new guidance, that they've had a couple pilot programs in the past that have led them to this, that previously our total supplemental payment programs, when our total payments, including supplemental payment programs, could not exceed what you may know as the UPL or upper payment limit, which really is you could not have Medicaid paying in total anything more than Medicare. However, this new recent guidance from this spring allows for total Medicaid payments that are made in relationship to Medicaid volumes that run through MCOs, which is the overwhelming majority of the Medicaid volume in our state, now to be no longer limited by the UPL, but now to increase that cap up to the average commercial rate. The size of the pies here is really the message from this. What is the opportunity? We have an opportunity to go from an old world where we were capped at UPL to a much larger pie for our total set of Medicaid payments. So what do we need to accomplish that? Because obviously, I think any one of us from a financial perspective would like to be part of that bigger piece of the pie, even if our slice, if we're the smallest slice in the old pie, we would like to be the smallest slice, at least in the big pie, to have a bigger portion there. So what needs to be accomplished to increase that capacity for the total pool is coming up with our state-funded portion. Most of you understand that Medicaid is a federal program that is funded on match dollars. That is, the state puts up a portion, the feds match that and return dollars back. And given that we are a low-income state, the match rate that we are assigned is very favorable. In fact, I just saw, it's not included in here, but I saw that the match rate for 2025 fiscal year, so next year, beginning July 1st, will be 3.53, I believe, meaning every dollar we put in, the feds put in $3.53. We put in $1 at the state level, we get back into the total pool over $4.53. So we got to find out how, identify how we come up with funding for that state portion. We have to develop a distribution model, much like our other supplemental payment programs for those who have been familiar or involved in those. We would need to gain legislative approval for that state funding. Then the governor needs to sign off on any legislation along with HSD concurrence, finally submission to CMS to make certain that we meet their criteria and guidelines for approval for that match to make this happen. How do we fund that state portion? That's really kind of the big ticket on that list back there that we need to accomplish first. And while we have seen those who have been involved with healthcare for long, it looked for like the past several years, CMS was going to no longer allow for provider taxes, along with what they released around the average commercial rate. Also was clarification and guidance. Provider taxes will be allowed to continue. And in fact, they issued guidelines for those. So we will need to implement a provider tax, which is broad-based across our participating hospitals, but can allow for some level of exemptions of certain hospitals or a portion of those hospitals, but is capped at providing the funding from that state or for that state portion at no more than 6% of the net patient service revenue across the state for the participating hospitals. So there are some limiting factors of how much of the state portion can come from a provider tax. I think it's important. Christina Campos, I didn't warn you ahead of time, but I think she said it very well as we look at our position here. As we talk about the crisis that is existing in our rural hospitals, that is a hot topic amongst our legislators, that our rural patients are having to travel further for care and urban hospitals are being inundated with patients. But it only works being the healthcare system, if every hospital is healthy enough to do its part. We have to help our rural hospitals, but we also have to have our urban facilities sustainable in order to provide that tertiary care and ability to transfer your patients. Having said that, we've set out some guiding principles in this process. First and foremost is, how do we maximize that additional federal funding opportunity? How do we get those additional dollars into our communities so that we can provide the service and the access that we need to, so that we can staff our hospitals, that we can provide the providers, so that we can keep the doors open. Second, and I will highlight and say this quote came directly from our largest hospitals: we have to protect our rural hospitals. So I appreciate the collegiality and the collaboration that we've got, and I think we all understand the impact of our hospital. John Harris has said many times, we are all interconnected, and what happens in one small hospital affects every hospital in the state. I think we get that. Third, we need to restrict the use of any provider tax funds to the state-directed payment fund only. For those who remember, when they passed GRT on us back in 2018, that we are now subject to paying GRT, we were not successful in getting those funds that they collected from us dedicated to only healthcare. If we are going to pass a provider tax, which is separate and distinct from GRT, so it should be an easier push. I'm not saying an easy push, but easier push. That there is one sole distinct reason for that, and that is for this state-directed payment program. All of those funds need to go directly here. We are not in a position to be adding any funds to the general fund for crime, education, you name it. The purpose of this would be for this state-directed program, and I will reiterate that part of what you'll read in the details is really the reason to do a directed payment is it helps us control the sustainability of the state-directed payment program. If it was to be funded solely off general funds, those who have been in this state more than 5 or 10 years know that our general funds go up and down. And if we fund a program such like this solely off general funds, we will be subject to cuts or reductions in this program, just like any other program when general funds are reduced. And the sustainability of this program, which is meant to sustain our hospitals, then becomes at risk. So let me cut to exactly what it is that we're proposing at this time from a structural perspective. We are proposing that we develop a funding that comes from a combination of first the provider tax up to the full 6%. That is what would be sustainable and ongoing into the future. We would look to see, we don't know this yet, but hopefully we can get the current county portion, the 1/12%, to count towards that contribution from the smallest rural hospitals. So that would reduce, or depending on what their 6% number is, maybe even eliminate any additional tax beyond that. We don't know from a legal standpoint and a CMS requirement standpoint if this is possible the way our county portion statute is written, but we're doing that research right now. We believe that there is a good possibility it could be. We would separate UNM from this into their own IGT. That's an intergovernmental transfer. Academic institutions such as UNM have a unique ability to fund separately, and given their high Medicaid volumes, when we get to the second portion of this on disbursement, it is beneficial to us to create UNM into their own separate class. Then if we still, between those first three components, don't have enough of the state portion funded to maximize the entire program that we could be allowed to have under the new average commercial rate, we would ask for additional general funds to augment that, knowing that in future years that is susceptible to being cut, but we want to do our best to maximize everything we've got. From a disbursement standpoint, we would want to create a model. We are aiming to create a model that the majority of the funds would be allocated much like HAP is today for those who are involved, or for those who are not, it is based upon volume. That is a requirement by CMS, by class, and is not at risk. Either a quarterly, most likely a quarterly payment made aggregating your total Medicaid MCO volumes for the previous quarter, multiplying it times the per click rate, and having a payment that comes out. Another portion of the funds to be allocated by performance, so at risk against quality metrics. That's another component that CMS requires. Trying to keep that percentage of the pie as small as possible, but still meeting the criteria. And we are suggesting to use the quality metrics that we have spent the last 20 months agreeing on, not only with HSD for what the metrics are, but the benchmarks and the scoring system that CMS has just recently approved. So we know that we are in alignment between the hospitals, HSD, and CMS on these metric criteria. There may be need for additional criteria to augment those. We'll see how that comes about in the process. As I mentioned earlier on the disbursement, keeping UNM in a separate class, their high Medicaid volumes put into any one class would become very disproportionate as things are distributed by volume. So leveraging their ability on the IGT to do their own intergovernmental transfer and have their own class for the disbursement. And then lastly, additional funds for HSD for increasing rates of non-hospital Medicaid providers that are that would not be part of the supplemental payment program as far as reporting and quality or volume-based allocations, but for increased base rates such as physicians, emergency transport, and I will say for our post-acute facilities, part of the modeling is going to determine whether or not it is better to have our post-acute facilities in the supplemental payment model, or in lieu of that, since they are not used to being a supplemental payment programs and the reporting that's required and how their volumes and quality criteria would be separate and distinct, if not kept in the program, then putting them in a position where they would instead receive an incremental base rate increase. In order to do this, we would need to sunset the HAP and the TAP funds. I don't know that there's a whole lot of crying and whining that I would hear about that. Part of the reason for that, TAP is no longer applicable the way it was intended. And for HAP, we just spent 20 months, as I mentioned, coming up with the quality metrics. One of CMS's criteria is you cannot use the same metrics for quality reimbursement in more than one supplemental payment program. So in order to expedite this process, since we've already agreed upon those, hence why we are making the recommendation to use those as our quality measures and sunset HAP so that those measures are all free to be used in a new supplemental payment program. I would assume that each one of you is sitting there asking the question, really, Troy, tell me what this means to me. How is this going to impact me? You're not worried about everything in total. I will tell you part of the reason for today's meeting is to start to sow the seed. And I'm going to tell you the answer to that question is, I don't know. We're not at a position yet that models have been run for me to have any idea what the individual implication on any hospital would be. But we have formed a steering committee and hired 2 national consultants who have done these state-directed payments many, many, many times. And specifically around the average commercial rate, I know of at least 8 states who have used the combination of our 2 experts, HMA and Iman and Associates, to successfully get their average commercial rate state-directed payment programs approved. So we'll leverage off their experience on putting together a program on the front end that we don't have to bounce things back and forth with CMS rejecting. They still have to go through approval. Doesn't mean they won't ask questions. Doesn't mean they may not question part of what we put together, but we hope to have learned from the other 8 states that have gone through this and move this through in an expedited manner. I will tell you on the front end, there are 2 items that I have in blue here that are very pertinent to each of you as to what does this mean for you. The second bullet point, I'll say HMA has told us it's going to take them 2 weeks to develop the first draft of various versions of the model of how they class people together, what the proposals are on the provider tax, what kind of exemptions could exist, whether or not the county portion could be allocated, how we can facilitate the taxing side, but also what the right hospitals are to group together for the distribution side. Once they receive that data from HSD, which is not included yet, they'll take that 2 weeks. Once they draft that first model, we will get this group back together and review that with the larger group for you to see, here's what they have come up with in helping drive the recommendations for what the models will look like. And I say that because I know there are many who say, I'd love to be part of the steering committee. I'm just going to address that now and say we have such a short time frame on this and quick turnaround. We have to keep this group small. And the purpose of the steering committee is to identify the structure and the guiding principles. We'll then work with all of the individual members and your finance folks, your corporate folks, your consultants to be able to review once we get the model pulled together. I will put a meeting date on your calendars as soon as I know the data has gone to HSD, so I have that 2 weeks heads up period of time for you. Once we receive consensus from the group that this is a model we can support, we will be finalizing it with HSD. I will tell you in the first bullet point, you'll see that HSD has a member included in the steering committee, so we aren't starting fresh at that point, that we've got them engaged along the way, but we'll get final sign-off and approval from HSD leadership and the governor's office We are targeting for that to happen and need that to happen really by mid-November. So you can now sense when HMA is going to take 2 weeks from the date that they get the data, which they have not gotten it yet, and trying to achieve a mid-November sign-off date, how short of a runway we have. Once that's approved, then we will begin to socialize this with legislative leadership, including the Legislative Finance Committee, which drives the decisions for getting into the budget. We are requesting with LFC to present at their final session, December 11th to the 15th. They already have a heads up. We've given them some information. They don't have any details because we don't have any details, but they will need to know what portions they need to include in the budget going into the session. And then lastly, we will coordinate educational meetings with our legislators that will probably start early December. Even though we haven't presented to LFC, we will have presented to legislative leadership, including LFC leadership. And this is where we will be engaging you in many aspects as we try to get out to every one of our senators and House members in an effort to educate them, as you can imagine how complex this is. What are some other key points we've got? First and foremost, we've been working with the governor's office since the summit that we told you about in August. The governor conceptually is on board and in fact gave us the go-ahead to take the lead on creating this model so we could do it quickly and efficiently. We have been in constant discussion and keep them up to speed on the guiding principles we have and how the model structure is laying out. They are anxious to see it too. And in fact, the governor wants to make this one of her bills. Hence, that is why this information is for you only, that we cannot find ourselves getting out ahead of our skis, to use a commonly used phrase, as this needs to be led by the governor, and we will be working with them on when we can start to communicate with legislators at large in greater detail. But we have to get the sign off on the governor, which I think is critical for us, not only to gain her help in getting it through the legislature, but clearly after anything the legislature passed, the governor has to sign off on it. As I mentioned before, that leads us to an extremely short and condensed timeline. I hope that makes sense. I want to reiterate the purpose of this. This state-directed payment offers us this opportunity to address our sustainability situation. It enables us to improve the recruitment and retention of providers and staff, which then provides for improving access for the community of our members. I want to start to sew these phrases into everything that we say in the future, even though I've told you this is not to be talked about yet, but from the earliest time, I want the underlying principles of why we're doing this. It's all about access to care. And we have to remember that's really what's driving this need for us and what we're pushing for the governor and our legislature to buy in. So in wrapping up, what is it that we need from you? There will be a data sharing requirement or data sharing agreement requirement that I have to have each of the facilities sign that allows and authorizes HSD to share the data that is needed, and I'll cover that in a second, between HSD and NMHA, and even more importantly, HMA, for them to run the models. The data they are looking for includes your basic discharges, days, volume information on the inpatient and outpatient side, and total charge or total net patient service revenue. The charges associated with everything, charges and net patient service revenue. The net patient service revenue you've already reported to me directly, but the charges from the combination of claims. There is no PHI, there is no individual claims level data. There is nothing that would allow either HMA or NMHA to be able to back into or calculate what any contracted rates would be for any individual facility. This is the high level data that we have shared back and forth, that we have been frustrated that over the last several years, HSD wouldn't share openly with us. There is nothing in here that could not be accomplished through an IPR request. We don't want to go through that time process. And it really, if there's anyone who's got concerns about that, please reach out to me. I don't think so, because we've signed one of these for the HAP volumes approximately 18 months ago. We have been asking HSD to just be open like they used to be and share this back and forth, but because HMA is involved, a new third party, we do need this signed, and we need as quick a turnaround as possible. We have asked HSD to start pulling all of the data based on the template that HMA needs. They are working on that. They will not release it until we have the last of the data sharing agreements turned in. So they are not waiting for us to get the data agreements to start to do their work in order to help shorten this timeline, but they will not release that to HMA. So I then won't know when HMA's 2-week time period starts until we get those back. I am currently waiting on HSD to get us the language for that data sharing agreement. I wish I had it right now to send out to each of you and have asked you to end your lovely Friday with returning it to me. But as soon as I get it, I will get that out. More than anything, that is the most time critical piece that we've got. The biggest time critical element in all of this program right now is getting the data to HMA to get them started so that we all have something to look at to answer that question of what does it mean to me. Secondly, email and call me with any questions or concerns individually. I know I've opened a can here to get everybody thinking. I'm trying to figure out how does this impact my budget? How does this impact us for as far as the taxing side or on the distribution side? The only thing I can tell you at this point is what I said earlier, is we are looking at a proposed effective date of July 1st of 2024. So having said that, know that over these next 8 weeks, I will try and give as much lead time as possible, but my number one objective is to keep everyone informed. That may mean that you get a meeting if there is something that comes up that we need to discuss urgently with extremely short notice. And I apologize for the short notice, but hopefully the magnitude of the size of those two pies that you saw earlier representing what this potential opportunity is, and knowing that we've got this legislative session to get through this and the short runway that leads, hopefully that makes sense. Since I sent this document out to you, I will tell you I'm not going to go through these slides. There's an appendix that gives much more detail on a lot of these slides that I have submitted to you. The other document gives even greater detail than the appendix slides here. So hopefully if you have individual questions, please review the remainder of this document on the appendix or on the white paper that was issued, and do please feel free to reach out to me. With that, I'm going to go ahead and open it up for any questions or comments.
Corey, this may be a silly question, but can we assume, and I know there's a lot of calculations that need to be done, that this will be neutral or better than what we're currently getting?
I will tell you one of the overriding, I think I'm going to use some different words. Oftentimes anytime you create a model with as many different hospitals and sizes and scopes that we've got, we use the term there's winners and losers. I think there's no way to have anything be perfect. I believe this is going to be a situation where there are winners and bigger winners. But the objective of the modeling is to class people together to be as equitable as possible. And I can only give you the reference on the size of the pies that our current HAP and TAP programs amount to about $105 million in supplemental payments. We expect, and we're waiting on the number to come back with the average commercial rate, but that this is going to end up somewhere between 1 and 2 billion. I don't know how anybody could come out with anything less than they currently have.
Okay.
Now that's 1 to 2 billion of total. And I kind of lined out for you the different buckets things would go in. So some of that would be at risk. Some of that would be for entities outside of our hospitals to get rate increases. But I can give you that range of magnitude that we believe our preliminary calculations from our estimates will have. But we're also waiting on the final actuarial report of the state on exactly what they will be able to certify is the average commercial rate for our state. Good question.
Thank you. Is just one other question until somebody else has one. Is this, I may have missed this and you may have said it in other words, but is it analogous to another state that has implemented this a similar type program?
There are several that have implemented program. We're probably closest to Kentucky, but I would say Kentucky implemented one, and this is probably more of a blend of our current HAP VBP program and Kentucky than anything else. Obviously, HAP VBP has nothing to do with average commercial rate and the size of it, but the level of the structure that we're putting into place with a provider tax is much more like Kentucky.
Okay, thank you.
Kansas is also fairly similar.
Troy, does this change the mix of the federal match portion?
So it doesn't change the mix of the federal match portion. The supplemental payment programs use the blended overall rate for the federal match, and that's consistent with the current supplemental payment programs that we've got because they cover across the. I don't want to get too detailed here, but the federal match rate is made up of components of the expansion population, your base Medicaid population, your adult, and that still applies to our current supplemental payments the same way it does, and it's the overall blended state rate that is used.
Okay.
Any other questions? There are no dumb ones. This is complex. This is not easy. I did my best to simplify this down with some great help from our steering committee on simplifying things and not getting too detailed. So hopefully this was helpful to everyone on the line.
Troy, what would this do to psychiatric hospitals, freestanding psych hospitals?
So I made the comment about our post-acute facilities. So whether it's our behavioral health facilities, our rehab facilities, or long-term acute care, they are in a category that I would say is we are waiting on. It depends on whether it's better to have them in the supplemental payment model, which would subject you to some new reporting and probably have to have us create new quality metrics, or whether it's better to carve the post-acute facilities out of that group and have, in lieu of that, a base rate increase across those facilities. So that is, we are waiting to see HMA, how they model it, what is the best overall outcome. And I will tell you, if it comes that on the financial side, if the answer is it's a toss-up, we will probably move for an efficiency standpoint and an ease of rewriting legislation to move it to an increased base payment as opposed to being part of the supplemental payment, because it's not something that is akin and normal for all of our post-acute facilities, whether they're rehab, behavioral, or LTAC.
Thank you.
So I guess the message I want my post-acute facilities to hear on this is you are not left out, but it is undecided whether you would be in the supplemental patient payment portion or if we would have to identify other means to have a similar effect through base rate increases.
Roy, I have a question.
Far away.
You mentioned that, this would replace the HAP and the TAP. Is there any guidance in terms of how we would determine the impact to DISH?
So great point. I fully expect for those who are DISH recipient hospitals that this significant, if we get all of this approved, there would be a significant impact on the increase in overall Medicaid reimbursement, which would reduce your eligibility and possibly, for many of our hospitals, eliminate your eligibility for DISH. So as we are running the models, we have brought that up to HMA, and they will run the models on what I will call a net basis that will look at the positive impact from this model, but reducing it by the loss of HAP, TAP, and DISH. So when we look
And
at the models, it will be a net position of the impact of all three of those.
thank you. And you'll also be including the cost of the premium tax in there as well?
Yes, absolutely. That's it. Yes.
Okay, thank you.
So not all hospitals are HAP or TAP participants, not all are DISH recipients, but the end model will end up being, when we look at the impact, here's what you'll receive, less here's what you would pay in the provider tax, less here is what you lose from HAP, less here's what you lose from TAP, less here is what your potential DISH reduction would be to be the net impact to your facility. Somebody's got something in the chat here. Just to thank you. Okay.
Roy, this is James. This may be a non-issue, but in another state, there was a moratorium on no new taxes. So we changed the language to get the federal match to provider fee. If it's a non-issue, it may even play better saying tax that we're taxing ourselves, but just FYI.
With our previous governor, I think that might have been an issue. That does not seem to be an issue at all for our current governor.
It's good.
Okay, one last call. I hate to keep people longer on a Friday than they need to be here, but I want to make certain that we are being open in our communications and getting you the information you need. Like I say, stew it over, chew on it. You've got 2 documents to help you follow up. We will have this recorded. If you've got somebody in your organization that you think needs to see this, more so than what the documents you've got, and please reach out to me, email or call. I would like to resolve as many concerns along the way because of our tight timeline. Obviously, right now, I don't have details by facility, but absolutely, if you've got concerns on the structure or any of our guiding principles, or even what it possibly could mean. I can't talk numbers because I don't have them, but how things might work, like Angela asking about the impact on DISH, et cetera, please reach out to me. The 2 weeks that HMA is working on the model, I'll have nothing to do other than answer your questions. That's a little facetious. I've got a lot to do, but that time frame, I hope to have all resolved so that when you all see the impact on your individual facilities with the outputs of the model, that it reduces the amount of time it takes for us to get to consensus. Okay. Thank you all. Appreciate all you're doing. Have a good Friday. Hopefully today's Friday does not mean 2 more work days till Monday for you, and you get to enjoy the weekend.
Nice work. Thank you.
Thank you.
Thanks. We'll go
Great
ahead and
weekend.
Thank you.
wrap things up.